What if I told you your doctor may have said something too confidently when they told you cartilage cannot regenerate? Would you believe me? And what if I told you scientists may be closer than ever to repairing damaged cartilage, possibly changing the future of osteoarthritis treatment with something as simple as a targeted injection? Sounds impossible? Maybe not, because today we're talking about research from late 2025 that has people in arthritis medicine paying very close attention. This is not hype. This is not a miracle cure, but it could represent a major shift in how we think about cartilage damage, joint degeneration, and the future of osteoarthritis treatment. And if you have knee pain, cartilage loss, or arthritis, what you're about to hear could matter more to your future than you realize. First, we need to understand something important. Let's use the knee as an example. Imagine a small defect in your cartilage, basically a tiny hole in the smooth protective surface inside the joint. At first, it may not seem like a big deal, but joints are constantly under pressure. Every step, every stair, every squat, every movement. That small defect is a lot like a pothole in a road. Ignore it, and repeated stress keeps hitting the same weak spot. Over time, that defect can expand. The cartilage can break down further. The joint becomes less smooth, less stable, and more irritated. But here's where many people misunderstand arthritis. Cartilage loss is not just a wear and tear mechanical problem. Biology matters too. When damaged cartilage starts breaking apart, tiny fragments can float inside the joint. Those fragments can irritate the joint lining, called the synovium. And once the synovium becomes irritated, inflammation can start building. Chemical signaling molecules become involved. Inflammatory pathways switch on. Swelling increases. Pain intensifies. Stiffness becomes more noticeable. And the cycle can begin feeding itself. That is one reason two people can have similar arthritis scans but completely different experiences. One person barely notices symptoms. Another feels like their knee is falling apart. Why? Because arthritis is influenced by much more than an X-ray. Your body weight matters. Your activity level matters. Your muscle strength matters. Genetics can matter. Metabolic health can matter. Even inflammation throughout the body can influence how aggressively symptoms develop. And when that process keeps progressing, some patients eventually reach the point many people fear most: joint replacement surgery. Now, here's the good news. We already have treatments that can reduce symptoms, improve function, and sometimes slow the disease process. But most first-line treatment is still non-surgical. Usually, that means some combination of exercise therapy, weight management, movement optimization, medication, and sometimes injections. Let's start with medications. Anti-inflammatory drugs and corticosteroids are commonly used because they can absolutely help control pain in the short term. And for some patients, they make a meaningful difference. But they are not risk-free. Used improperly or too often, these medications can irritate the stomach, affect blood pressure, influence blood sugar, strain the kidneys, and create other issues depending on the person. Then, we get to injections. One of the most commonly used options is the corticosteroid injection. Yes, it can calm inflammation quickly. Yes, some patients experience dramatic short-term relief. But here's the part many people do not hear clearly enough. Repeated steroid injections should not be treated casually. Research has raised concerns that repeated intra-articular steroid use may contribute to cartilage loss over time in certain situations. That does not mean steroid injections are useless. Far from it. In the right patient, used strategically, they can be valuable. But they are not a forever solution. Another commonly discussed option is hyaluronic acid injection. The idea here is to improve the joint environment and potentially improve lubrication inside the knee. Some patients report meaningful symptom relief. But there's a trap. People get temporary improvement, come back months later for another injection, then another, without ever addressing the bigger picture. Because if you rely only on injections but ignore strength, body weight, movement quality, and long-term joint loading, you may be managing symptoms without truly managing the disease. That's why injections should support a larger plan, not become the entire plan. And that larger plan matters. Strengthening matters. Smart physical activity matters. Building a joint that can tolerate real life again matters. For the right patient, these changes can dramatically reduce symptoms and sometimes reduce the need for repeat injections. Now let's talk about PERP. Platelet-rich plasma. This treatment has received growing attention in orthopedic medicine, particularly for selected patients with mild to moderate knee osteoarthritis. The concept is that concentrated components from your own blood may help influence inflammation and symptom control. Some patients appear to benefit. But let's stay honest. PERP is not a guaranteed cartilage regenerator. It is not magic. And it does not mean osteoarthritis has been reversed. It may be a useful tool for selected patients. Nothing more, nothing less. There are also surgical cartilage restoration techniques, especially for younger patients with more localized cartilage defects rather than advanced end-stage arthritis. These approaches can involve matrix-based repairs, collagen-based techniques, and other restorative procedures. Some patients do extremely well. But surgery comes with rehab, cost, recovery time, patience, and the need for very careful patient selection. Which brings us to the research that caught so much attention. In late 2025, researchers at Stanford Medicine published findings involving cartilage aging and degeneration in mice. Important point, this was not yet a human treatment, but what they found was fascinating. The scientists targeted an enzyme known as 15-PGDH. When they blocked this pathway in aged and injured mouse joints, something remarkable happened. The cartilage showed signs of regeneration. The animals also demonstrated reductions in osteoarthritis-related pain. And that matters. Because one of the biggest frustrations in arthritis medicine has always been this: we have treatments that reduce pain, treatments that improve function, treatments that buy time, but very few that genuinely push damaged cartilage toward repair. That is why this study generated attention. Not because arthritis is suddenly cured, not because knee replacements are disappearing next month, but because it suggests something important. The biology of cartilage regeneration may be more flexible and more targetable than many people were taught to believe. So when someone says cartilage regeneration is impossible, they may be speaking with more certainty than the science currently supports. Now let's be careful. This does not mean severe osteoarthritis can already be reversed in humans with a single shot. It does not mean you should abandon evidence-based treatments and wait for a miracle therapy. What it means is this: we may be entering an era where arthritis treatment becomes more regenerative, more biologically targeted, and potentially less invasive than what we have today. And that is exciting. But until these therapies become real-world medicine, the fundamentals still matter. Movement matters, strength matters, body weight matters, nutrition matters. And for many people with osteoarthritis, complete inactivity may actually make things worse. Many patients notice their pain increases after becoming more sedentary, during recovery periods, after injuries, or after avoiding exercise altogether. Because joints often need intelligent movement, not permanent rest. Some patients benefit from injections. Some need structured rehabilitation. Some may be candidates for PERP. Some eventually need surgery. But the people who often do best are the ones who stop searching for shortcuts and commit to a long-term strategy. Because that is how you reduce pain. That is how you protect function. That is how you buy time. And while we wait for regenerative technologies to move from laboratory science into human treatment, the smartest thing you can do right now is understand the disease and fight it the right way. If you found this helpful, subscribe, turn on notifications, and keep learning. because the more you understand osteoarthritis, the harder it becomes for the disease to control your life.